raise your hands up over your head like this. Doctor, put your cell phone down. Okay, everybody kind of go like this with your hands, like that. All right. Look at that, isn't that great? Okay, now what you're doing is you're checking the blood supply to your arms to see how quickly the blood is getting into your arms. This is called Ruse test. If you feel like you have some tingling in your fingertips, that means that the blood supply could be blocked or narrowed in the thoracic outlet space, and that you have some compression of your thoracic outlet. Now, you'd be surprised, this talk is about thoracic outlet syndrome. And as a young athlete, I was 20 years old, was playing rugby for Las Vegas Rugby Club, and I was a hooker. And now, don't get excited, because a hooker is really the guy in the middle. He's not one of those, let's not get into that. But if you know rugby, the hook is like a guy that is sort of a human sacrifice. They put him in the middle, and you lock your heads together, and they throw the ball in the middle, and there's this fever of excitement. Everybody wants the ball, so the hook, there's two on each side, and they hook the ball back into the scrum, and then when the scrum gets possession, the scrum will break free, and they'll both run after whoever's got the ball. At times, unfortunately, the scrum will collapse. And that's because when the athletes are pushing against each other to gain territory, then they lose their footing on the slip on the surface or whatever. In Santa Barbara, when I played, it was 4 inches of water in the bottom of the field, and it was slippery mud because there was 70 teams playing that weekend. And on either side of me were two 100-kilo guys, and behind me, two 100-kilo guys, and another guy behind him that's 100 kilos. So there was 600 kilos of pounds of pressure pushing against me from behind, and 600 pounds or maybe 1,000 kilos coming from the front. The prop on the left side slipped and fell, and I went head first into the mud puddle. Okay, and I hit my head on the hard part because it just kept going through the soft mud, and my head hit the clay, and I felt my neck snap back, and I couldn't breathe. I had the wind knocked out of me, and I felt this terrible, sharp, excruciating pain between my shoulder blades, and because I couldn't breathe and I was under the water, I was drowning, and it took them a long time to get off of me. And then I felt this hand pick me up out of the water, and then I coughed up all this mud water out of my lungs, and I felt like I was saved. I saved my life. After that, I had some symptoms of concussion, and finally found out that I had 3 broken ribs on the right side. Those ribs didn't heal up for 7 years. I had thoracic outlet syndrome and excruciating pain between my shoulder blades for 7 years. And at a time, I was on a date I was a single guy, a doctor, and I went on a date with a young lady, and I really liked her. And I was going to impress her on the fact that I was schooled, educated, And so she kept seeing me do like this, I kept having these nervous tics, and she said, "Why do you have those nervous tics?" And I said, well, I wanted to be professional. I say, well, because I have this thoracic outlet syndrome, I have muscle spasms in my neck, and I can't find a comfortable position. She looked at me like kind of, and she said, what do you do for a living? I said, I'm actually a doctor. She said, oh, okay, nice to meet you. Like as if, I couldn't take care of my own problem. I went to school while I had this condition. I was with doctors every day. They couldn't figure out what was wrong with me. The chiropractors were doing adjustments on the back, making me worse. And the numbness went down in my fingertips, and I lost grip strength. It got worse and worse by the day. Finally, I figured out how to correct this problem. This condition is one of the most difficult conditions that you'll ever have in your office. It is so complex. It's difficult to diagnose and extremely difficult to reverse. In fact, it's so difficult to reverse that there isn't even enough insurance dollars in American system at times to be able to apply to this condition to actually reverse it 100%. Okay, now, thoracic outlet syndrome is often underdiagnosed. What does that mean? That means that you say, well, you have carpal tunnel syndrome because you have numbness in your fingertips, but also that people think that human beings are only entitled to one diagnosis. However, I find it common that we have complicating diagnoses like carpal tunnel, median nerve entrapment in the forearm, hyperabduction of the shoulder, and thoracic outlet on top of it. If you're just going to treat a carpal tunnel or you're going to treat a thoracic outlet syndrome and you don't address all those complaints at the same time, by the time you figure out that you underdiagnosed the patient, they have other complaints, you're on visit number 9 or 10, you have to start on that condition. The patient's just looking at you like this. Shake my head, as we say in America. Because you've wasted all that time, that valuable time that you need to actually reduce those other conditions. It's commonly misdiagnosed and commonly found out after several surgeries. We'll do carpal tunnel surgery and we find out that they're no better. And then we do herniated disc surgery and they don't have any improvement. And then you say, oh, could it be thoracic outlet syndrome? By that time they have all these scars and these failed attempts at reducing the problem, and it's embarrassing that you made a misdiagnosis. They had to go through all those traumatizing surgeries before you finally figured it out. So it's the most underrated, most misdiagnosed condition of the upper extremity. This is the anatomy of the thoracic outlet. Okay, this is the thoracic anatomy here, and as you can see, the neck muscles, I was just talking to this lady earlier. She was doing a lot of stretching of the neck like this. She was, oh, my neck hurts, and going like that. Well, here you have the scalene muscles that attach on the third, fourth, and fifth cervical, and they attach on the first rib. Not many people realize that you have the anterior, middle, and this posterior scalene muscle attach on the first and second rib. And so when you actually stretch your head to the side, you have like a 4.5 kilo weight that is dangling from your neck, and the muscles are actually elevating the ribs these ribs can get elevated into the thoracic outlet and start to pinch the nerves and also the blood vessels, the artery and the vein. The first sign that you're going to find with an elevated rib is tingling in the 4th and 5th digit. Now, then you have the subclavius muscle right here that can get swollen and pinch the blood vessels and nerves, so you can have an elevated rib, swollen subclavius muscle. Also, the subclavius muscle, when it's in a muscle spasm, it's commonly used when we're driving the car, using the mouse, our cell phone, so on and so forth. So it's commonly spasmed. This muscle will actually drop the collarbone down, or the clavicle, and it lifts the rib up. Both of those conditions will cause a compression of the thoracic outlet area. However, in the literature, the subclavius muscles are infrequently mentioned as a cause of thoracic outlet syndrome. I find it to be the most tenacious muscle spasm, and it's the most painful and swollen muscle when I have patients with this condition. Then you have the pec minor, and then you have the coracobrachialis and the biceps short head. When you're using your cell phone, the first thing that's going to happen is that you have an anticipatory reflex that will anchor the shoulder down to your chest. So when you're going to lift this piece of meat, it's kind of heavy, and you're going to put it in front of you, you have to have a counterbalancing mechanism. Biomechanics tells us that the pectoralis minor drops the shoulder down to the chest and provides a solid foundation to lift the arm up. So when you hold the cell phone here, you're actually using the coracobrachialis and the biceps short head and the anterior deltoid to hold the cell phone here. Now, if you're told that you need 10 repetitions in the gym, and then you set the weight down, and then you wait 90 seconds, and then you do 10 more repetitions and set the weight down, let the blood get into the area to rejuvenate the tissue with oxygen and nutrients, why would you think it's a good idea to hold your cell phone here for 4 or 5 minutes straight and have constant contraction of these muscles, sustained contraction of these muscles to hold the cell phone in that place while you're browsing or looking up or reading articles. So you have to make changes to that. So in the literature, primarily what is mentioned for thoracic outlet syndrome is the anterior and middle scalene and the pectoralis minor. And the surgery that's done for patients that have compressed thoracic outlet is that they'll surgically remove the anterior scalene muscle, the middle scalene muscle, and the first rib. And if it's also suspected that the pec minor is pulling the shoulder down into the outlet, they'll surgically resect the pec minor, called a tenectomy. Now, if you are treating an athlete, these muscles, obviously, the scalene muscles stabilize the head and help you to have good postural orientation of the head on the frame, on the body's integrated spring system. And these muscles are very important in stabilizing the shoulder. When you start surgically removing muscles, you could end the athlete's career. So you want to do everything you can to avoid surgery. The reason why I bring this up is because the incidence of thoracic outlet syndrome is going up dramatically. When I first started writing my book, Google tells me, according to analytics, that, you see, scientists, doctors like to quote some figures, but Google is really the authority on how many people have these conditions, because that's how many people are doing searches. These are your patients. So I'd rather take Google statistics than statistics by doctors that are people that are entering the doctor's office, because people don't have insurance. They don't go to the doctor. Those statistics don't get counted. These patients that are on the internet, they're clicking around looking for a solution to their problem. 74,000 people. When I did the talk in Thailand a couple of months ago, it was at 60,000. When I first started writing my book, it was at 48,000. So you have a lot of patients that have this condition that maybe you don't know it and you're not treating it right, or basically, and also here's the other factor. The factor is that everybody's got a smartphone now. In fact, the kids all have them. When the patients come into the office, they give the smartphone to the child. Would you just play some games while I get treated? And the child's got his head down like this for about a half hour looking at the smartphone. The muscles get short, and when they lift the head up, they raise the ribs up into the outlet. So these conditions are actually getting started at a really early age. And these children are actually getting surgeries for thoracic outlet syndrome in their teens because they're addicted to smartphones, cell phones, the mouse, the computer, using the computer too much. And taking a cell phone away from them is like, back in my day, I'm like a middle-aged man, so I can say that. When my mom wanted to punish me, she said, "You have to stay inside." Now the mom punishes by saying, "You have to go outside," because the computer is inside, So things have switched. So an average American is spending 11 and a half hours manipulating gadgets. So you're manipulating gadgets for 11 and a half hours. We didn't have only one phone. It was sitting on the wall, and we didn't even have answering service. Although, how did we even manage back in those days? But now, you cannot have that many contractions of the shoulder, the neck, and the fingers and the muscles and still have a healthy upper extremity area. So the history started off 1861 was the first rib resection so that was a very long time ago. And these are the names of thoracic outlet syndrome, from cervical rib syndrome, Paget-Schroeder syndrome, Effort thrombosis, bilateral thoracic outlet syndrome, neurogenic thoracic outlet syndrome, vascular thoracic outlet syndrome. It becomes very confusing to not only the patients, but the doctors as well. I looked up all the websites from the biggest thoracic outlet syndrome surgical centers that are, the hospitals that do these surgeries, Johns Hopkins and Baylor. Baylor's been doing surgeries for years. And they say it's a compression of the neurovascular bundle as it passes through the thoracic outlet. So these are the treatment approaches that are used according to PubMed search. I read all 2,500 articles that have been published on thoracic outlet syndrome and took copious notes because I wrote a book about it. So I know what these therapies are. And these are the 16 different treatments that are recommended for thoracic outlet syndrome. Which one of these treatments by itself now will actually reverse thoracic outlet syndrome? None of them. None of them do. It's a combination of multiple different therapies. Now, the main reason why patients get surgery for thoracic outlet syndrome is a failure, the physical therapy program. It's not properly managed. It doesn't address the problem accurately, correctly, and there's not enough treatment rendered. And so the other reasons are because if you have like a blood clot in the subclavian vein, when the outlet gets compressed enough, narrowing of the subclavian vein can create a blood clot, and that blood clot can actually, normally the way it's reduced is that a catheter would be put into the vein, and then clot busters will be used to bust up the clot. And then normally, doctors will immediately the next day go in and remove the rib and the scalene muscles and the pectoralis minor. But doctors at Stanford University tried on some patients to just see how it goes by not doing the cervical, by doing the decompression surgery. And the outcomes for those that did not get the surgery and those who did have the surgery are actually about the same. So there is a possibility that you could actually just do the catheter clot busters and reduce it that way without the surgery and still get good results. Monitor the patient very carefully, blood thinners of course, but the other reasons are from arterial compression as well. Surgical outlet, thoracic outlet surgery has poor outcomes in workers' compensation cases, and they're really not the same as they used to be because they've had parts of their body surgically removed, and they're hard-working people lifting heavy pieces of wood and beams and carrying them across to different areas, working with heavy concrete, a lot of them, and they're not really the same. The other thing is if you do the surgery on one side, there's an imbalance in strength in the muscles, and they just can't get used to it. So it's difficult for them to resume the same exact treatment or occupation that they did before. Now, there are subtypes of thoracic outlet syndrome. Neurogenic is one I treated in case in China where they had tingling in the fourth and fifth digit and difficulty with some grip strength. But when I tested the blood supply by taking the pulse and doing Adson's tests, which I'll show you later, that there was no reduction in pulse. Also, I brought with me this pulse oximeter. When I'm doing tests on patients, I put this on their finger to determine the pulse rate and determine the oxygenation of the blood. And in fact, one patient that came to me had severe thoracic outlet syndrome. All he had to do is put his shoulders back and the pulse oximeter just shut off. So the other symptom and sign he had was tachycardia. When he would get in traffic, he would tighten up, and then his heart would race, and then he would have to pull over. He would feel nauseous, and he'd feel like he wanted to go to the hospital. And then his wife had to drive him for 6 months because he couldn't even drive anymore. That's how bad these conditions can get. Well, we've actually treated him, and then those symptoms and the signs actually stopped. So we're able to reverse it just with decompression, non-surgical decompression. So you can affect the heart rate with this condition as well. And so it's a narrowing of the blood vessels in the nerves as they come through the outlet. This is a common presentation of the patient. These are, when people complain of pain in the upper back here, these are most likely the ribs, the first and second ribs that have elevated due to a muscle spasm in the front of the body. So we are always working on these muscles, massaging them, doing percussion. We do some therapy, muscle stim, ultrasound, and you're kind of wasting your time because you're going to get some of the inflammation out of there. But in reality, the muscles that are pulling these ribs out of alignment that are causing this pain are in the front. And if you don't work on those muscles, they're never going to get better, and it's going to be embarrassing when they find another doctor that does. Here also, the third, fourth, and the fifth rib in the front can be elevated by a contraction of the pectoralis minor muscle, because the pec minor attach in the coracoid process. So if the pec minor is in a spasm because they use the cell phone too much, then that lifts third, fourth, and fifth rib up, and it causes a subluxation of the costotransverse and costovertebral junction of the spine, and also it can cause chest pain. So patients have chest pain, they think they're having a heart attack, and then they have the numbness in their arm and a numbness in their fourth and fifth digit, and they absolutely think they have a heart attack. They can't breathe because the pec minor is pulling and squeezing so hard on the chest and the rib cage that the rib cage can't expand properly to get full oxygenation into the lungs, and they start having rapid breathing, tachycardia. They start thinking they're having a heart attack, and they show up at the hospital, and after about $13,000, $14,000 worth of diagnostic testing, all come out negative, they find out that it's thoracic outlet syndrome with a problem of the ribs. That's embarrassing. How is the body designed? Now, this is where I discovered my own cure for thoracic outlet syndrome, and what we need to know: how it's engineered, how it protects itself, how it recycles energy, and how it provides spaces for so the bones won't bang. So we have, like, how do we stand up like this without our knees clanging? And how do we run without our knees clanging, our hips clanging? How does that happen? It creates the space, or the thoracic tunnel, so these blood vessels and nerves can pass properly. Because if you don't know that, you can't treat properly thoracic outlet syndrome, herniated discs, and other compressive disorders. And we have a problem with those. A lot of them are going to surgery when they're not medically necessary. So this will give you a better insight onto that. So here are the three models. We talked about this in 2014 when I did my talk here. The inverted pendulum model, which says that when we take a step, we actually put the lead leg out as a straight leg, and we use our back leg as to pole vault the mass as our body over the lead leg like this. And so that's what was determined back in the late 1600s by Borelli. Borelli developed this model, and it's more of a lever-based model. The ankles have rockers in them that allow us to absorb the impacts and the like. And then the spring mass model, which we'll go over in a minute, but the legs are like linear springs, and they absorb the impacts of walking and running and sports through these springs. And then I developed the new model called the integrated spring mass model. It did not include the spine and did not model the ankle joint into that model, and so therefore it was incomplete. So we went over the lever model, and this was who kind of helped me to decide that the model was not accurate. We need a new one. It was Professor Yuri Veroshansky from Soviet Union, and some doctors, Dr. Gagny. We went to Russia with Dr. Ed Enos from Concordia University, and the first person I asked to have on the lecture for my sports medicine course, I was 26 years old, and I ran the first sports medicine course in Moscow at the former Soviet Union and in the National Institute of Physical Culture. And I invited him to speak, and this is he and I look the same, right? I try to look the same. And that's a friend of mine who passed away recently of esophageal cancer. And so Dr. Veroshansky developed plyometrics, which we do in sports. And this is the model that's the spring mass model here, which shows that a little bit better way of how we absorb impacts by way of the body as a spring system. And so you have different types of springs, constant rate spring, and then progressively loading spring. And here's their model. As you can see, they don't have the arch of the foot, and they stop at the spine. So everything above the hip was considered the mass. And so I created the arch as a suspension system with suspension system tendons, and the shoulder is actually a suspension system. The roof of the thoracic outlet is the shoulder. So how is it that rugby players, football players can go full speed and hit the other player as hard as they can? They're running full speed too and not sustain injuries. Is because the trapezius and the levator scapula are like a suspension system. Suspend the shoulder from above and hold it up. So when we drop the shoulder down, it springs right back up again. It does not allow the shoulder to actually come in contact with the blood vessels and nerves. And so you have a football player that hits really hard and does not get thoracic outlet syndrome, but a 60-kilo lady doing the computer has a complete numbness of her arm, loss of grip strength, and the thoracic outlet is completely compressed. Why is that? So when we're doing the surgery on thoracic outlet syndrome, I wanted to mention to you that most of the therapy is directed towards these three muscles here, anterior, middle, scalene, and the pec minor. But these are the other 6 muscles that compress the outlet that are not included. So this is what we already went over, and I'm not going to go over that. Now the nervous system, here's something that is very simple, okay? If you have a compression syndrome, like I have herniated discs, okay, I'm perfectly fine. The Japanese did a study where they had 497 volunteers that were completely asymptomatic. They have no back pain, never had an injury. They have no neck pain, and they did MRI scans of these perfectly normal people, and they found that 34% of them had huge herniated discs in their back. Now, they did a follow-up study on the neck, and they found the same percentage, around 34, 35% of the patients asymptomatic had huge herniated discs in their neck. In fact, 7% of them were so big that they were compressing the spinal cord. Now, if you have a little car accident, you come in, you're not getting much better, and you have some tingling in your arm, and you do an MRI scan, and if you're one of the 34% that had a previous herniated disc you didn't even know you had, now the doctor now thinks you have a herniated disc as a result of the car accident, and you're being whisked into surgery for surgical decompression. So these, if you don't understand these statistics, and if you don't understand how to examine for thoracic outlet syndrome, and you make that mistake and they come out of surgery and they're the same, there's an unhappy patient, that's for sure. And you just don't want that to happen. Now, in the spring model, we have 2 different things that we talk about that are different from the lever model, and they're pretty fascinating. Spring compliance is if we take like a jog, a light jog. We have a compliance spring that absorbs impacts better. And if we have spring stiffness, that means that we tightened up the spring and the muscles tightened up the tendons and allows us to ricochet or bounce off the ground. With a more stiff spring, we can move faster with more efficiency. However, we take up more impacts in the body. So there's a give and take there where the athlete that's a full runner, like a marathon runner, they have the combination of the protection from the looser compliance spring, and they have the stiffness of the stiffer spring to provide the efficiency to win faster, run faster, and that's what we're looking for in training. Muscle stiffness is not the same thing as spring stiffness. Like for instance, if I'm running, I just have a light, like a compliance spring. If I want to run faster, you'll see that what you do is you just tighten up the muscles, which puts more tension on the tendons to run faster. I could feel my body tightening up to ratchet up the tension on the tendons to allow the body to move faster. Now, when you're talking about thoracic outlet syndrome, if you have a loose or compliant spring system like the suspension system of the shoulder, then the shoulder girdle will drop into the outlet and cause compression of the nerves. So women, some of the ladies are more apt to get thoracic outlet syndrome, 4 times as many. In fact, doing studies, there's 125 people who had surgery. Of those, 25 were male and 100 of them were female. And I believe, in my opinion, females have some other occupational things they do, like they lean back with the baby like this, and they put pressure on their neck when they do that. And also, their necks are thinner than men. They're not as strong neck. They don't do like shrugs and those kind of activities, heavy lifting. These postural, I want to go over postures, one of the main causes of thoracic outlet syndrome. Like if you have an athlete, okay, if you have an athlete that has thoracic outlet syndrome, you maybe think there's something wrong with their performance or something wrong with their sport. In reality, they're 22 years old and leaning back in the couch watching sports, or they're leaning back watching doing Xbox or whatnot, or using the cell phone too much. So here's the righting reflex. As you can see, the baby has the head perfectly perpendicular to Earth, and the eyes are on the horizon. That's done automatically for you. Sir Sherrington did the research on that in the early 1900s, where they determined if it was from learning or from reflex, and they cut the connection between the midbrain and the cerebellum and then retested the animals, and they found out that they still had this reflex centering of the head, and so they determined that the righting reflex was actually automatic and it's not learned. So in this case, like for instance, on this patient, the patients will come in and they'll tell me, they'll sit down, I won't even read their history, and they say they have numbness on the right side, okay? And then the wife is there and I say, well, he sits on the left side of the couch when he does his work, right? She goes, how do you know? Kind of blown away. But science tells us that if we have thoracic outlet syndrome on the left or on the right, then we're leaning to the left, because what happens inside the semicircular canals is that there's a gel material on top. There's some hairs in here in these semicircular canals, and there's a gel on top of it. So when you lean to the side, gravity takes that gel, trips the hairs, and then you have an opposite. The brain creates a contraction of the muscle on the opposite side to right the head on center. So if a patient has thoracic outlet syndrome on the right, then you can bet their bad habit is leaning to the left too much. So this is give you some insight on treatment of thoracic outlet syndrome. My time is up, and I wish I had more time, but if you have any questions, or would you like to learn more about it, you can visit my blog at thoracicoutletsyndrome.com, or visit my author site at drstoxen.com, or to really learn more about it, go to amazon.com and purchase my #1 best-selling book, The Human Spring Approach to Thoracic Outlet Syndrome. With that, I'd like to thank you very much for attending the lecture, and I hope to see you all after the program. Thank you.